Hey there, this is a video on the GI symptoms occurring in pediatric age group. Let's start with vomiting. This is how I remember the causes of vomiting based in a chronological order for my step 1 exam, and this is how I choose to remember for my CS exam as well. So, if there is vomiting at birth, then it is esophageal atresia, and then at 1 to 2 days, then it's partial duodenal atresia, and on X-ray there'll be a double bubble sign. And if it is from 2 to 6 weeks, then it's pyloric stenosis, and usually the vomiting is projectile here. And then biliary atresia, there is vomiting in it, but the chief feature in biliary atresia is, however, jaundice and not vomiting. And at the age of 6 to 24 months, we'll have celiac disease. That is no surprise because weaning begins usually from 6 months onwards. And if you're suspecting annular pancreas, the presentation will be years of non-bilious vomiting. And gastroenteritis and hepatitis can be a cause of vomiting, whether be it in adults or in children. So, and then another way to remember the diagnosis is vomiting. This side there is projectile vomiting and non-projectile vomiting. So, at 1 to 2 days, esophageal atresia or tracheoesophageal fistula, and on 1 to 2 days there is intestinal atresia, intestinal obstruction. Here, the vomiting is bilious. Any vomiting after the sphincter of OD is bilious vomiting. So intestinal atresia or intestinal obstruction presents as bilious vomiting, but it presents within 1 to 2 days. So any atresia anywhere, if there is arthritis, then of the intestine, then it presents earlier. And then 2 to 6 weeks and 4 weeks, we have projectile vomiting. Pyloric stenosis causes projectile vomiting at 2 to 6 weeks of age. We can also see peristaltic movements from the abdomen. So we have to ask the guardian for that. And then there is annular pancreas. That can also cause projectile vomiting. These both are non-bilious. Next, going on to constipation and abdominal pain plus vomiting and bloody stool. So in constipation, the first thing is meconium ileus. We anyway in birth history ask the mother or the father whether the child passed his first stool and when did he pass his first stool. And if the answer is more than 24 hours, then we have to suspect meconium ileus. And if the baby has meconium ileus, there is high chance that the diagnosis is cystic fibrosis. And the other causes of constipation are Hirschsprung's disease and anal atresia. So basically these three present immediately at birth. At birth, there will be delayed passage of meconium. And then hypothyroidism is a very important cause of constipation, and it doesn't present immediately at birth because of the maternal thyroid hormones. And when the maternal thyroid hormones we know go away, that's when the baby will present with constipation, lethargy, less activity, and then enlarged tongue. Obvious causes of constipation can be low fiber diet, and in babies there's lead poisoning, and then celiac disease. This again presents at 6 months of age because that's when the weaning starts. And the workup: rectal exam, barium enema, suction rectal biopsy, and anorectal manometry. Moving on to abdominal pain, vomiting, and bloody stool. So for abdominal pain, vomiting, and bloody stool, we'll have lower intestinal obstructive causes. So the obstructive causes in babies are intussusception, volvulus, and Meckel's diverticulum. In intussusception and volvulus, we have red currant jelly stools. And then necrotizing enterocolitis is one of the most important causes, especially in premature baby and formula-fed infants. So it's very important to ask the guardian what are you giving it at diet, and was the baby born at term. Blunt abdomen trauma also can be one of the causes, and gastroenteritis, whether it is adult or pediatric case, gastroenteritis can always be the cause of vomiting or bloody stool. If the child is an older boy or girl And the cause of abdominal pain can be malingering somatoform disorder. So for this, we ask any stress. Has there been any stress and major stress that the child is facing, or has there been any stress or major event in the family like divorce or illness? And then child abuse, lactose intolerance, and IBS. Just like we have celiac disease for babies, we have lactose intolerance and IBS in younger children. The next symptom is jaundice, and the most important causes of jaundice in children, in babies, is physiological jaundice and ABO compatibility. This is very important for us to remember. And as usual, neonatal sepsis. And the question we ask is, did the mother have any infections during the pregnancy, or did she take any medication for that? So that's the one question with which we can put neonatal sepsis as a differential diagnosis for fever or jaundice. And ABO incompatibility is very important because we have to ask the mother what is her blood group, what is the father's blood group, and what is the baby's blood group, and did she have any such, did she have any miscarriages, or did the child's sibling have any such problems? However, that is a very important question in familial hyperbilirubinemia uh, diagnosis. All right, so now we are going to divide the causes within first week and after first week, and there are some similarity and differences between the causes, so it's very easy to remember. Within first week, it is breastfeeding jaundice, which means the baby is not feeding properly and there is low bowel movement, because of which there is more time for bilirubin to get reabsorbed into the system. As there are no colonic bacteria in a baby of uh, in the baby within 1 week, so there is no bacteria to break down the bilirubin and it gets reabsorbed. So if the baby is not feeding properly, then there is low bowel movement and more reabsorption of bilirubin, causing breastfeeding jaundice. After 1 week, this becomes breast milk jaundice. Here, the baby will be feeding well and he will be gaining weight. The second cause is a familial neonatal hyperbilirubinemia, and a pertinent question here is family history of sibling who has required phototherapy. So it is important for us to remember that any metabolic disorder related to bilirubin will present within 1 week, and any other metabolic disorder of the liver will present after first week. So that's simple. The next diagnosis is related to blood. So if it is ABO incompatibility, it presents within first week. And any other hemolytic disorders like G6PD, spherocytosis, and thalassemia can present after first week. And biliary atresia presents after first week, and it is the most common cause of hepatic transplantation in kids. The other causes that happen within first week are birth-related trauma, cephalohematoma, and polycythemia. The questions that we ask relating to these diagnoses is, uh, we follow the usual mnemonic that we've been following, but in intensity, we ask the guardian what is the extent of involvement. That is it only until face, arms, or full body? And quality, would you describe it as light or dark? And I've added B over here for blood group. So for jaundice, the pertinent questions that we have to ask is blood group and onset. When did it occur? Was it present at birth or after 1 or 2 days? And these are this mnemonic, SAW, which we follow for babies. There is nothing new over here. And apart from the HPI mnemonic, the review of symptoms mnemonic, and SAW that we ask for pediatric cases, the only extra questions that we ask for a pediatric case are related to birth history, immunization history, nutrition, and development. So in birth history, I have divided it into prenatal, natal, and postnatal. So in prenatal, we ask the mom, apart from iron and multivitamins, were you on any meds, or did you take any drugs, alcohol, or smoke? Were you diagnosed with any illnesses, and did you take any medications for those? And for jaundice, we ask history of any miscarriages, like I told before. This question we are asking in view of blood group mismatch, and if the mother has any illnesses during her pregnancy, it means that the diagnosis the cause of jaundice for the baby is neonatal sepsis. And then natal, the questions which we ask over here is, was the baby born at term, and what was the mode of delivery, and were there any complications during the delivery? And on postnatal, was the baby normal, or did he have any problems after being born, and when was the meconium passed? That is postnatal history. And in immunization, we just ask, is the child up to date with vaccination? And in nutrition, what do you feed the child? So whether it's breast milk or the baby is formula fed, and if the baby is formula fed, then when it is added to the diet and what the diet looks like now. In developmental history, we ask weight, height, language, and developmental milestones. Has the baby been gaining weight appropriately, and what about height? And has he attained all the milestones at appropriate ages? And the parents are going to answer to that, and then we ask, is there any access to growth charts? So this is the only thing extra for all the pediatric cases that we are going to ask. And that completes jaundice and all the other GI symptoms for a pediatric case.